This intracoronary imaging and physiology is a very essential topic, and it's gaining momentum, and the use is being increased in US as well. As Bilal Bhai will share his experience over there. In Japan and other countries in Asia, it was being used much more frequently with PCIs. But as the data has come out and evidence has come out in favor of the imaging, especially and with the IFR technology, the use has increased a lot in US as well. So that background in mind, in Pakistan, I think we lag behind in these new technologies because of cost issues, but we need to stay with the curve so that, and we need to find a solution as to how we can have access to these technologies to use them more frequently, because it does have impact on outcomes as well. So IVUS basic understanding and image interpretation. I'm going to start with the basics because we have a lot of fellows attending this talk as well. So when you start with CT angiography, you're talking about 230 to 600 micrometers of resolution, and with angiography it gets better. With IVUS it gets further better with 100 micrometers resolution, and OCT it's like high definition, very nice. So you can see a picture below how clear it keeps getting, the Mona Lisa picture with the imaging from CT angio to OCT. So what is IVUS? A catheter pulls back through a lesion or area of interest and results in series of tomographic cross-sectional images of the vessel. Sound waves are reflected or pass through structures depending on their density or acoustic impedance, and 60 images are produced in a 1 millimeter segment using a pullback speed of 5 millimeters per second. And what are the technologies available? We have two, Boston Scientific and Volcano, which is now taken over by Philips. So the Boston Scientific is a single transducer which rotates like the lighthouse effect on a drive shaft at 1800 RPMs. And the phased array solid state transducers is multiple 64 stationary transducers which emit the ultrasound waves. Now this is phased array. It does not have as high frequency as the rotational catheters. So Eagle Eye, which we have over here, this is 20 megahertz typically, and you can get on rotational catheters 40, 45, and with some of the other rotational catheters up to 60 megahertz frequency with resolution, a better resolution. And this is the OCT image with the even better resolution over here. So phased array versus rotational, if you were to buy, the rotational catheter has a better resolution, but there is blood speckle in the lumen, needs flushing before insertion. It is easier to cross. It's less bulkier than the phased array catheter, the rotational catheter. Resolution is better. But for CTO crossing, because it is closer to the tip, this phased array catheter, so that may be preferred only in that scenario. This is the Volcano catheter that I have in the lab. For the beginners, you just plug and play. It's very quick. You just plug it into this over here, and and you slide it over like a monorail system, like any balloon you would do. And this is the slide with which it is connected, which does a pullback. It's a very basic slide which lets you do a pullback with this. So intracoronary ultrasound catheters advance down the coronary artery, and it's the ultrasound waves are perpendicular. It's coming perpendicular to the vessel like this, and you get cross-sectional images of the lumen. Why ultrasound? Why coronary angiography cannot explain by itself? Because you're looking at a straight picture of a three-dimensional structure. So it's a cross-sectional image over here of a lesion. If you look in ROLO view, it's a completely concentric lesion. It would look the same. But if it is an eccentric lesion like this, it would look fine in the RO view, but look very tight in the LO view, and you would never know what exactly the diameter of the lesion is, how tight it is. And in a complex lesion, look hazy in both the views, but look mild, and it may be tight with this complex lesion over here. There's another example. If you're looking at a lesion from here, it will just appear mild, 20% stenosis. If you're looking from here, 40%. You're looking from here, it looks like a 60% stenosis with eccentric like this. So that's why IVUS imaging can further elaborate the lesion. So when would you use IVUS? If you're using it before PCI, you would use it for left main significance. We'll elaborate further on all these points. You'd use it for culprit lesion in acute coronary syndrome. You can use it for angiographically ambiguous lesions and you can use it to assess stent failure and also determine the risk of distal embolization. During PCI, you would need it for lesion preparation, CTO crossing, selecting the right landing zone, choosing balloon stent diameter length, evaluating the result after stenting, especially complex lesions like left main, bifurcation lesions, and calcifications, where all the data is coming out in favor that it changes, has impact on hard outcomes as well by using IVUS and OCT in these settings. And with IVUS, you can reduce contrast volume as well. So basics of the grayscale, the more less dense the tissue, the more equilucent it is. So media appears, smooth muscles appear dark, and fatty tissue appears dark. As it gets fibrous and calcific, it appears more white, and adventitia appears more gray. So, and fibrofatty and fibrocalcific will be mixed over here in these shades of gray. So this is looking at a normal vessel with a catheter in here, and this is the border of the lumen. This is the intima here. This dark is the media, and outside of this is the adventitia over here. There's another example of that. This is the intima over here. This is the interface between the vessel lumen and the intima. This is the media over here and adventitia behind it. And this is the coring guide wire behind which you're seeing the guide wire artifact. So if you're seeing the coring guide wire on the side, that is the Boston Scientific catheter, because with the phased array catheter, you don't see the guide wire in the lumen. So that's one advantage, I would say, of the phased array catheter there. So this is histopathology being correlated with the IVUS images. This is the intima, media, and adventitia. How does it correlate with IVUS? This is the media highlighted over there. Then this is the adventitia outside highlighted over here. And inside, this is the intima over here, which is plaque is dense with different shades of white or gray, depending on if it's lipid rich or it's fibrous or calcific. So this is in the long view image interpretation of the same thing, as will be highlighted all the structures over here. This is your catheter being shown. Then you have the media being highlighted over here. Then you have the plaque being highlighted here, and then the calcification over the plaque and the blood inside. So now this is how you would do a lumen dimension, that you would draw the borders within the lumen and get diameters like this. And this is how you would do the EEM dimensions, by drawing outside in the external elastic lamina, outside the media border. So IVUS image interpretation, when you look at the image, you're going to see, is there a plaque? And if it's normal, it's normal. If there's a plaque, then is it within the lumen or the wall? If it's within the lumen, then is it hypoechoic? If it's hypoechoic, it's chronic thrombus. And if it's hyperechoic, is there a shadow? If it's a shadow behind it, it's a calcific nodule. Otherwise, it's an acute thrombus. If it's within the wall and it's hypoechoic, then it's likely a lipid-rich plaque if it's an equilucent area. And if it's hyperechoic, then it's going to be either calcium or fibrosis. If you can see fibrosis over here. If it's calcium, you're going to have a dropout of the ultrasine waves behind it, and it's going to appear white. I can't move it down. So intracorneal ultrasound image of the over here, minimal plaque highlighted here. This is the moderate plaque highlighted over here. And and this is an example of a lot of times you don't get these clear, crisp pictures, but this is an example of a thick fibrous cap over here, as you can see, and this is an example of thin fibrous cap. This will be, so diameter stenosis would be the same in both, but this is much more prone to plaque rupture because it is much more lipid-rich plaque with the thin fibrous cap over here. So this is the one plaque you're looking over here on with the yellow highlighters. This is an example of a fibrous plaque. This is shades of gray, a little bit more white, but there's no dropout behind it. This is mostly fibrous plaque over here. This is an example of calcific plaque, which is 90-degree arc over here. So this you would be easily able to fix without much lesion preparation beforehand. And this is an example of deep calcium over here behind, and superficial calcium over here, which bothers us the most. And with a mixed plaque with fibrous tissue in between. This is an example of calcification in white over here with a echogenic calcific fibrous mixed plaque, and there's an equilucent area behind it, and there's acoustic shadowing behind the calcific area. Again, calcific plaque highlighted over here. just multiple images for helping with image interpretation. So this is the lumen over here, and this is the calcification and bright areas with acoustic shadowing. Behind the calcification, there's the reverberation effect that you get, and shadowing you can get as a result of that high calcification. Now, this is a little bit of calcification over here. No problems with this going with a stent. You want just some dilatation you want to do and then put a stent in. This full 360-degree off arc of calcification, typically more than 270-degree arc of calcification and stretch, you would need to address it with a plaque modification for calcium much with your tools, root ablation or IVL before you put a stent in over here. So on angiogram over here, this is a normal vessel portion looking on the ultrasound like this. And this is the circumferential calcium over here. You will not be able to open this with just NC. It would be very hard. You would need to address and modify the plaque with arterectomy, likely in this case with this circumferential calcium. And this is the stented segment, the stent starts, as you can see on the IVS over here. So this is an example of a ruptured plaque over here. And this is the lumen border, and this is the vessel border, the EEM outside over here. Then this is the well-opposed stent in the vessel wall. This is an example of intimal hyperplasia. Intimal hyperplasia appears with very low cogenicity, and sometimes it can be really hard to see, and flushing can help, as it did over here in this case. Then over here, this is an example of a fully opposed stent to the plaque. Over here, it's a grossly malopposed stent that you can see over here. This is an example of SCAD. So this is a true lumen over here, and this is the false lumen that you can see over here. The IVS can confirm these SCAD findings. There's an example of thrombus, very hard to see generally, but very well delineated over here. Now, this is after stenting the RCA. This lesion was not well prepped at the ostium, and as a result, it's really an underexpanded stent in over here because of the fibrotic lesion. Sometimes you get the ostium, you need to use a cutting balloon before you put a stent in over there, but well expanded over here, but really underexpanded. So IVS helps identify the underexpansion, which would have impact on long-term outcomes there. Then example of intramural hematoma over here. So it can help you with lesion treatment if there's a hematoma over there, which you identify beforehand. Now, left main disease is very crucial before you commit somebody to doing a bypass or complex left main intervention. Both have high stakes there, and you want to be sure that that left main is tight. So this patient got sent for bypass twice. This was shared by someone else, and eventually he got an angiogram. I was done after his angiogram. The bypass grafts keep closing. The patient continues to have chest pain, which is to begin with either non-cardiac or an OCA. And there was, on IVS, he did not have a significant lesion. But it appeared like this because sometimes you have oblong-shaped left veins, which may appear tight in some of the cranial views, and caudal views, they'll appear fine. But when in doubt, when there's ambiguity, please use imaging. Now, there's another example of left main hazy lesion by angiography. And, this area appears normal. And this is 3.6 millimeter significant plaque with heavy calcification in the distal left main. So for left main, what are the cutoffs? The studies with 7.5 millimeters square, the studies with 6 millimeters square, and in the Asian population, there have been studies with 4.5 millimeters square, which with FFR greater than 0.8. So, but I typically use 6 millimeters square. If anybody in our population is 6 millimeters square or greater left main area, you can safely say that that is not significant. Anything below that, I would want to use physiology or clinical scenario to commit them to revascularization for left main. This is a very busy slide, not the intention for you to memorize or look at it. I mean, go over in detail. These are all the various cutoffs, as you can see, anywhere from 4 to 2.4 for what is significant in the vessels, in the non-left main vessels. So in the left, because everybody is born with a different coronary size. So for the non-left main, you can't use an area to say that we should intervene on this. You should use physiology or clinical scenario. But generally, for 4 millimeters square and above, you can safely say that that is enough area, whatever the plaque burden might be there, to defer that lesion in the non-left main vessels. So a ring down artifact is a word about artifacts which you see with the phased array catheters. You have to push the ring down button. This is the ring down artifact. NERD is something which you see with the Boston Scientific catheters, that when you are around the bends, when you're pushing the catheter in the sheath, that it moves it can cause this effect over here. So you need to be watchful of that, and when you're pushing it through the bends over there. And this is the blood speckling over there, which you can clear with flush. Then sometimes there can be a lot of axial catheter motion. With each beat, the catheter moves back and forth. You should watch out for that. And when you're pulling the IVUS catheter down, a lot of times I'll disengage it, because just otherwise you can miss the ostium, and you can mistake the guide catheter for aorto-ostial stenosis as well. Reverberations and side lobes are something which you see with a very echogenic, bright calcific lesions, or that you can have reflections of that created. These reverberations and side lobes are examples of that. Now, this is a feature which we have available with the Volcano machine, which is that you have a color coding of various frequencies of the ultrasounds that are returned back, and you color code them, based on which you can assign fibrotic, lipidic, necrotic calcification with reasonable correlation with histopathology of the plaques that has been done. It is not used in routine. It is a feature available on your Volcano machine. You can switch it on and see. It is for research purposes, but is not used in routine. Another feature on the Volcano machine is the chroma flow, which can help sometimes identify, like in this case, color going behind this dissection flap helped us to identify that. In this case, the color flow behind it, you could not tell if it's attached to the plaque or there is blood behind it. You put on color flow, chroma flow, and you could see that blood behind it, and it was actually malapposed stent over here. Now, stent optimization using IVUS is a big thing for which we use IVUS. So I'll go over briefly that. Pre-intervention assessment, you're looking for plaque morphology, identifying the landing zones, and choosing stent length and diameter. Lesion preparation, stent deployment, apart from confirming landing zone, you prepare the lesion based on the calcification you see and whatnot. Whether you're going to do just a non-compliant balloon arthrectomy or lithotripsy. And after determining the success, then you're going to deploy the stent. And then after stenting, you look for whether it's underexpanded, deformed, or malapposed, whether it's dissection or hematoma or tissue protrusion. Is there a geographic miss where it is landed? So this is a simple, to remember, MLD max, a simple abbreviation to remember. So morphology, length, diameter, and then medial dissection, opposition, and expansion. These are the things you're looking for in pre-PCI and post-PCI, just a MLD max, and easy to remember. Pre-PCI imaging, assess lesion severity and plaque morphology. So this is a nice illustration. So you did a pre-PCI imaging, you found this. No way you will be able to get a stent down there without addressing this lesion properly and get a proper stent expansion. So you had to do an arthrectomy over here, and you see the breaks in the calcific plaque, and then this lesion is ready now for the stent to be deployed. So this is after plaque modification, you assessed again, and this is ready to be deployed now. The stent is ready to be deployed there. Now, pre-stent imaging determines stent size and landing zones. So on angio, both these landing zones will look perfectly fine. But this is okay as a landing zone, not this, because this is more than 50% plaque burden. So just remember that to identify the landing zone. Now, this has an MSA of greater than 5 millimeters square. After the stent deployment, how will you assess? So this is an MSA of greater than 5 millimeters square. This is in green light. We're good with that because the stent area was 6.5. You want it to be 5.5 millimeters square or greater. And over here, this is not in red because you have the stent in more than 50% plaque burden. So this is not good. And this is also in red, that if you see this flap, then means there is an edge dissection which you need to take care of. So this in longitudinal view, how you can choose a stent length and area where to land. So this is the, you're going to start with the normal healthy area at B1, where there's no plaque, less than 50%. B2, again, an area, normal healthy area with less than 50% plaque. And then you measure the length in between them. In the longitudinal view, it's a time pullback, so you can measure the length as well. This is an example of here that with the vessel diameters proximally and distally to the lesion were measured. And, the diameters were anywhere from proximal 5 to 4.5. And distally it was 3.1. They ended up choosing a EAL diameter of 3.5. I would have still gone with a 3.0 and then stretch it proximally further up. Because I always size based on the EM to the distal reference. So what are the ultimate criteria? These are the most commonly used. Minimal lumen cross-section segment of greater than 5 millimeters square. Can everyone else mute so that can everyone else mute their thing? It's we can hear noise. Minimal lumen cross-sectional and stented segment is greater than 5 mm square or 90% of distal reference lumen cross-sectional area, or plaque burden at the 5 mm proximal or distal to the stentage less than 50%, and no edge dissection involving the medial length greater than 3 mm. So this is what you're looking at. So plaque burden less than 50%, statistical inspection greater than 5 mm square area, and no dissection for a stent to be properly deployed. So what I use is that I use the lumen diameter of the distal reference. And if I'm using EM, I use a ratio of 0.8 typically. And then I stretch the proximal portion of the vessel depending on the proximal vessel diameter and do NC 1:1 for the distal and proximal reference diameter. But start with a stent with 1:1 lumen diameter of the distal. And if using EM, I round it down to 0.8. If I'm using OCT, I will still keep it at 1 because OCT tends to get diameters a little smaller than the IVUS. So, and in the end, as mentioned, you want an area of 5.4 millimeter square or more, at least 90% of distal reference lumen area. So why this 5 millimeter square cutoff came off? Because data shows that if you have 5 millimeter square or greater area, you do much better based on the IVUS, XPL, and Ultimate trials data out there. So much better with hard outcomes as well. Now, stent malposition is not as important as we thought. It didn't have negative impact as has been shown in multiple trials, sub-analysis. And over here, highlighting the same point that we mentioned, that distal reference, distal edge, in-stent minimal lumen area, those things matter the most. These are statistically significant, and the proximal reference as well. The other things, not as much. So what about the area of confluence and left main after stenting that we are aiming for? So we used to have this rule of 5 for the circ, 6 for the LED, 7 for the confluence, and 8 millimeter square for the left main. But this has changed in the recent trial done. 8.3 millimeter square is what you should aim for after stenting for LED, 5.7 millimeter square for the circ, and for the point of confluence, 11.8 millimeter square. That did not have any statistically significant impact, but the other two did. If you had it less than 8.3 and 5.7 in the LED and circ, it was considered underexpanded with adverse outcomes at 5 years follow-up. And this is now co-registration system, which is widely available on all the US with the Philips machine, especially, that you do a pullback of the IVUS with the angiogram, and you can see all the points on the angiogram correlating with the IVUS image over here. So it's much easier in planning the stent deployment. What about OCT? A brief word about OCT. Because it's not widely available, you can still purchase it in Pakistan. Our RIC has it. So it relies on back-sectoring reflection of light over here instead of ultrasound waves. And it has 10-fold higher image resolution than IVUS. Now we're using the Fourier domain OCT. Illuminant Opinion Doctors Trial all have put it now as equivalent to IVUS. It had better images. We just didn't have the data. And now we have data also supporting its use, that it's clinically, in terms of hard outcomes, is as good as IVUS. So OCT using light, you need blood removal, so you inject dye, and axial resolution is much better, 10 to 15 micrometers over here, but the depth is less. So for left main, large vessels, it's a problem. And pullback speed is much faster with this. This is, again, simple plug and play, easy to use. If you inject this light emitter moves from point 1 to 3 within the sheath quickly, and the light waves are reflected back in terms of how much absorption they have and how much reflection they have. So that is the back scattering based on which the wavelength with which the light returns that the image is created. So this is the OCT catheter, coronary guide wire, and you can see the OCT catheter, coronary guide wire here very clearly is still intima, media, and adventitia over here, a much better resolution than any of the IVUS images we saw before. So how to interpret the OCT image? Can the EL adventitia be visualized? Yes, so this is a normal image. This is a fibrous plaque image over here. And is the signal change the lumen or the wall? If it's within the lumen, then it has to be a thrombus or a calcific nodule. But if it's a red thrombus, it will be high attenuation. There's going to be blackout drop of it. If it is white thrombus, there'll be no dropout out of it. In the lipidic plaque, there's be high attenuation like red thrombus. So over here in the OCT with the light waves, what happens is that you have a black dropout with a soft plaque, like lipid plaque, because there is high attenuation of the light. So it is a less penetration over here. But the calcific plaque, actually, there's low attenuation. less drop out of the light, and you can see more depth of the calcium. So that is the advantage also with the OCT, that you have low attenuation of the calcific plaque. Is the opposite over here. The soft plaque has higher attenuation and calcific plaque has low attenuation, and you can see more depth of the calcific plaque with OCT. There is an example of the ruptured plaque over here, nicely shown, ruptured fibrous plaque and necrotic core of the cavity over here. There is an example of SCAD again, subintimal hematoma, though I wouldn't advise using for OCT for this, because you have to inject while you have the catheter in there. That may make the dissection worse. IVUS would be preferred in that scenario. This is an example of a cross-sectional image of the histopathology with the IVUS and OCT. Over here, this is the calcified plaque. There's a dropout behind the calcium, so you can't really see the depth of the calcium. In this case, the calcified plaque over here, you can see all the depth of the calcification over here in the OCT image. So then a nice example of a cutting balloon used over here, and it gets better in angiogram. But look, the images of this area on IVUS, you can see it over here. But in OCT, you can actually see the fissures created by the balloon, which helped open the vessel. This is an example of a post-stent deployment IVUS. So you can see the stent over in IVUS and the lumen, but in OCT, you could actually see the intimal growth on the stent. So, this can help you decide whether you want to take off the second antiplatelet, if somebody, so this is really nice that you can see the intimal growth over here as well. Now, this is nice example of a angiogram with the IVUS and OCT at the same level. So you can see a little bit of dye hang up after the stented zone in this RCA. And this is over here, the dissection flap you can see, but you can't really well appreciate it on the IVUS. This is an example of malapose stent over here, which you can see in both OCT and IVUS of this segment, which you could not appreciate on the angiogram alone. And this is an example of plaque protrusion, which with the dropout behind it would either be red thrombus or would be a lipidic plaque causing this. So IVUS versus OCT, obviously for plaque morphology, OCT gives better images. It would be preferred for CTO, left main, osteal lesions, advanced CKD. For obvious reasons, you would use IVUS because left main bigger in size. CTO, you can't use OCT there. Osteal lesions also, you need to have the pull back all the way back into the ostium control. And advanced CKD, you don't have to inject for IVUS. So what is the clinical trial evidence to support use of IVUS and OCT and guideline recommendation? So IVUS XVL at 5 years data now we have, you see clear advantage of intravascular imaging. This was IVUS in this case, showing benefit over angio-guided, and Ultimate 3 showing the same over here, IVUS over OCT. Now, Ultimate 3 was mostly driven by target vessel failure and revascularization. By itself, there's a trend towards mortality, but when you combine them together, the composite of cardiac death, MI, stent thrombosis, and cardiac death, much better with IVUS versus PCI when the data was combined for Ultimate and IVUS XPL. So, impact of IVUS-guided PCI in acute coronary syndrome. So all the trials done in ACS combined together. This was a meta-analysis of 9 studies. It was favoring IVUS over here as well. And this was a study actually reported in ACC 24, but very own Xiaoling Chen, the friend of our society from China, and Pakistan was actually part of the study as well, including NICVD, PIC, and RIC was contacted as well. But I did not have the Boston Scientific Machine, but again, showing trend towards clear favoring the IVUS in ACS setting as well. This was IVUS was angiography guided PCI. This is a systematic analysis of 9 and meta-analysis of the 9 RCTs and 10 observational studies, which showed IVUS guided PCI decreased risk of cardiovascular by 33%, MI risk by 39%, and TLR by 19%, and stent thrombosis by 43%. Now I'm going to switch to the over here OCT data. We have aluminum 3 trial, which showed that it was as good as IVUS. They used EL-based stent optimization in this trial. And as I said, for this one, you can use directly the stent diameter based on the EL diameter of the distal reference segment. If I use IVUS and I'm using EL, then I round it down to 0.8 of that, or I use the lumen area. Because OCT tends to give a slightly lesser diameter than IVUS. So opinion trial, doctor's trial, again, validating OCT. Opinion trial, 1 year similar maze between OCT and IVUS, and doctor's trial, OCT-guided PCI resulted in better post-PCI FFR than angio-guided. And so there's a meta-analysis of OCT-guided versus IVUS-guided PCI. That the conclusion was that OC-guided PCI with IVUS-guided PCI demonstrated no significant dissonance between the two modalities regarding the incidence of MACE, cardiac death, TLR, TVR, target vessel MI, stent thrombosis, all-cause mortality. The choice of imaging modality depends on availability of necessary technology and resources and operator expertise. So Renovate Complex PCI, where they use both OCT and IVUS. This was a trial which showed difference in hard outcomes as well. And this was presented in 2023 at the ESC. And this is the outcomes data from that. So image-guided stent optimization in these complex lesions, 6% target vessel failure versus 12.3% angio-guided. And even for those people, you did not meet all the required stent criteria for the trial, but you did image-guided stent, tried image-guiding stent optimization, at least you had 8.9% lower than the angiography-guided. And what about the, this was to present to Greg Stone in the ESC back in 2023, with intravascular imaging using 17 trials, 11,000 patients, and 318 events. It favors intravascular imaging over angiography, and it includes all the major landmark trials over here. And you can see over here, compared with angiographic PCI, intravascular imaging guided PCI, this includes both OCT and IVUS trials. OCT and IVUS reduces target lesion failure by 31%, driven by 46%, 20%, 29% reductions in hard outcomes like cardiac death, MI, and TLR. Similarly, stent thrombosis reduction by 52%, and all MI by 18%, and death by 20%. So outcomes are similar for OCT-guided PCI and IVUS-guided PCI. A lot of talk about vulnerable plaque as well. I mean, you can identify vulnerable plaques with this. That's where we stand right now, and you should be aggressive with medical therapy. You find a vulnerable plaque, but do we know that local preventive PCI makes a different hard outcomes of doing a non-significant vulnerable plaque? There's not enough data to support it as yet. So what do the guidelines say? They are 2A, but they're still behind. These are 21 revascularization guidelines for left main, intermediate left main stenosis to confirm defined lesion severity, and using it for complex PCI. You can use both OCT and IVUS, and for stent failure as well. It is a 2A recommendation. But the 2024 CCS guidelines have made it a class 1 recommendation for IVUS OCT use and complex lesion, particularly left main, stent, true bifurcations, and long lesions. These are the trials to watch out for. And what can we do in terms of recommendations for intravascular imaging? There's a nice recommendations from a Mera et al. Trial. I think from Pakistan's standpoint, for complex lesions, we should encourage use of that. And all major tertiary care centers should have use of IVL intravascular imaging, IVI available. They recommend in US, all the cath labs should have it. And, from programs and sessions like this, we should expand training to all the interventional cardiology operators, because it should become a norm for all interventional cardiology operators to be able to at least know how to do it for their complex lesions and offer it to people who are willing to pay for it and who can afford it at least. Now, it's 9:37. It'll take me another 15 minutes. Can you bear with me, or should we do it later? Can you hear me? I guess I'll continue for another 15 minutes and then wind up the coronary physiology as well. Is that okay?
I think the discussion will then, we won't have much time, Noman.
We can extend it to like 10, 15, 20 minutes of discussion, or because, kya kehte hain?
I think physiology is important. You should continue.
Chale, but I'll just...
The other way to think about it is that physiology is so important that it probably deserves its own session, So there's a lot to talk about it. Whatever we decide.
Let's continue. फिर discussion उसके बाद शुरू कर लेंगे सारे.
चलें, ठीक है. So about coronary physiology, basic concepts, definition, and criteria. We've known about the impact of coronary physiology back in 70s when Grunzig, they fixed the stenosis, and before and after fixing the stenosis, the pressure gradients dropped across the coronary. So we've known about that fact for a long time, just not have been able to clinically use it. So resistance in the coronary circulation, you have, this is the epicardial vessel where you're going to be doing the FFR and non-hyperemic pressure ratios. The CFR does measurement of both the epicardial and the intramyocardial measurement. So R1 is the resistance of the epicardial tissue, R3 is in the intramyocardial, and IMR is also something which is coming up, which can be used for the ANOCA patients that you have. So in the dog model, you had correlation with the stenosis of the physiology as well. But then humans, the anatomy does not correlate with physiology. So we are a little different than the dogs, I guess. So this is an example of how much variation you have between the significant FFR and the coronary stenosis. So many non-significant stenosis also had significant FFR. Visually, that appeared non-significant in angiography. Now, this is the complex, physics behind how the FFR came up, but I'll give you a simplified version. What is fractional flow reserve? Maximal achievable flow, as achieved by maximal exercise or maximum hyperemia, is directly proportional to myocardial perfusion pressure, that is hyperemic distal coronary pressure. So flow is equal to pressure change divided by resistance. And assume in this case that resistance is equal in microvascular bed and venous pressure is 0. So based on that, you're left with just pressures as a marker or correlators of flow, and thus the fractional flow reserve, the flow is PD over PA, and the ratio of that will be, that is the distal pressure measured by the pressure wire divided with the pressure measured in the aorta, and the ratio of that less than 0.0 is considered significant. And what is IFR? A new non-hyperemic pressure index of stenosis severity is IFR. IFR is calculated by measuring the resting pressure gradient across the coronary lesion during the wave-free portion of diastole when microvascular resistance is low and stable. And it measures the physiologic impact of a coronary lesion on the distal coronary bed. A value of 0.89 over here is considered significant. So this is the guide catheter. You're measuring pressures from here. That is your P aortic. This transducer at the tip of the wire is your distal pressure, P distal. The ratio of that will be FFR after hyperemia. IFR is measuring it during this wave-free period, and it seems to correlate well with the FFR in terms of physiology. And PDPA is just resting pressure from the aorta versus the distal pressure over here. Now, practical tips to do the measurements and the artifacts to watch out for. This is set up in my lab. The pictures from there. This is the 0.014 wire, and you just take out from the packet, and I just flush this ring in which the wire is placed. Let it sit for 30 seconds. Then I hand over this wire to be plugged in over here. Once you plug it in, automatically it says wait for zeroing over here. And this is the console which in the lab on which it's saying wait for zeroing over here. And once it's zeroed, then it says ready to insert. Then you can insert it and bring the wire to the tip of the guide catheter. This proximal portion of the radiopaque area is where the pressure transducer is. So you're going to bring it to the tip of the guide catheter, and then you're going to move this insertion tool out, flush it with saline, and then once you have a clear tracing of both the pressures, you're going to press normalize. And that will tell you that the pressures have equalized, and then you're ready to advance it through the lesion. So this is an example of a case done recently, that this patient kept having exertional angina, but his stress test was equivocal, and this lesion was moderate. Initially had an angio done, he was told moderate lesion, so we decided to do an IFR and FFR of that. So we put wire across the lesion, and we give nitrates, and then later on, then we checked the IFR for this, and this was 0.88. And then I gave intracoronary adenosine about 100 micrograms, and the FFR was 0.76. This lesion was stented. He's feeling much better now. So physiologic assessment steps: remember, flush and zero the pressure wire. Insert pressure wire to tip of guide. Remove introducer. A lot of times people forget to do that. Flush guide with normal saline and equalize pressures. Advance pressure wire distal to the target lesion. Measure resting physiologic index, which is you can measure IFR and PDP at rest. And if the PDP is typically less than 0.91, if you're getting that, it's going to be significant. Measure hyperemic FFR. You can use intracoronary. Traditionally in the trials, intravenous adenosine has been used. Pull back and always check for drift. So if diffuse disease, pull back can help, and always check for drift, because there's innate thing, much less in the newer wires, that sometimes pressure of the distal area starts dropping on its own. So always pull back after you've done the measurements to the tip of the guide catheter. Make sure the pressure is still equalized. How do you achieve hyperemia? Use the same dose as used in adenosine stress, maybe 140 micrograms per kg a minute. And after 2 minutes, you start seeing the full effects. You have to watch out for dyspnea, hypotension, AV block, which are transient. Intracoronary adenosine, what is the right dose? A lot of variability. I typically use 50 to 60 micrograms for the right and 100 micrograms for the left. And if they're tolerated well and you don't see the effect, you can give further doses. And do always give intracoronary nitroglycerin beforehand to rule out any spasm over there. So, the trials have studied dose of 7 to up to 500 micrograms plus doses of adenosine, but that's what typically I do, and traditionally most people use as well. Common cause for errors: variability of the aortic pressure, transducer height. So make sure the transducer heights are equal for both the transducer. Inappropriate pressure wire calibration, debris on the pressure wire connector, not removing the needle guide wire introducer, using guide catheter with side holes, contrast medium in the catheter, you need to clear it with flushing, and excessive intubation of the guide catheter can cause ventricularization of the aortic pressure and it can go down. So just keep all these things in mind when you are doing your measurements. Pitfalls during measurements, wedging, whipping, and drifting. I'll show examples of all these. So in this case, you did a measurement, FFR was 0.9, but you can see the aortic pressure tracing is ventricularized. So when you pull back the guide, actually the FFR was significant because the aortic pressure was coming falsely low over here because of the guide intubation. So be mindful of that the guide should not be aggressively engaged in causing ventricularization. Then is an example of whipping. The wire tip is in a small vessel hitting the vessel wall. So this is resulting whipping. So just treat just the distal tip of the wire. And the transducer is hitting the vessel wall over there in a small vessel there because of then you're getting the whipping artifact. Which is the gradient or which is the drift? So this is the true gradient. If you're seeing the tracing of the distal pressure, this in green, exactly similar to the aortic pressure without some of this ventricularization that you see, likely this is the example of drift over here, and this is the example of true gradient. So FFR pullback pressure drift has occurred over here. As you can see, the distal tracing is similar to the proximal tracing, the aortic tracing. And so this suggestion of drift, you pulled back and you found that in the guide catheter tip also the pressure was not equalized. When you equalized and did the tracing gain, actually the FFR turned out not to be significant as a result. So there was a drift of the distal pressure. Some case examples for practical use. This was a lady who came to me for, had a ACS non-STEMI, had a tight clear LED lesion. And she was referred to me because she had been told that she can just get an LED stent. Somebody said she needs a bypass because she also has probably significant left main disease. So, I decided to do an IFR of both through the LED and the circ. She had a clear tight lesion over here and Wellens T waves. I did an IFR of the circ, it was 0.81. And IFR obviously through the LED was going to come at significant with 0.71. So clearly the distal left main area and ostial circ is also significant. So they decided to commit to left main bifurcation PCI. She didn't want to go for CABG. She's around 8 years old. So I just mini cone crush technique. And you can see it's nicely open over here. She's doing well on follow-up. This is an example of ostial circ lesion, which is being hidden because of its takeoff is such. And sometimes you can take all the orthogonal views and can't see the ostium. But when you did an IFR, patient had typical symptoms and no other lesion could be found. This was significant over here. The example of multivessel CAD, you can help decide, this is obviously clearly tight lesion. This is 50%, this is 60%, 70% over here, what to treat, what not to treat. You did an IFR, circ is clearly tight, you fixed it. RCO you weren't sure, that is clearly tight, you fixed it. LED was non-significant, you left it alone. So multivessel CAD, you can use it. Serial lesions, there's a right with a moderate appearing lesion in the proximal portion, long segment, a very tight lesion over here. So when you did an FFR over here, it was 0.92, which was being affected by the distal lesion over here. And when you put the wire out there, FFR was 0.6. So you fix the distal lesion and measured the FFR again. Now it has 0.7 because the distal lesion is not affecting this proximal lesion measurement. And when you fix the proximal lesion as well, now you have a non-significant FFR all throughout at 0.87. So an example of how you deal with serial lesions and how they can impact the proximal lesion measurements. Now with the co-registration and IFR pullbacks, life has become much more easier. It can show you where the step up or change in gradient happens the most and where you would get the most benefit for stenting. Special scenarios coming to an end soon, hopefully. Aortostomy lesion is you disengage the guide and you have to be watchful of that. For left main lesion, assess both LED circ. Ostial left main lesions, you have to give IV adenosine if you're going to do FFR measurement. CTO donor vessel, I just recently had a lesion with about 60% LED and CTO of the right. I opened and the FFR across the LED before was 0.79. When I fixed the CTO of the right, the FFR went up to 0.83 because the area supplied by the LED was now much less. So the FFR, IFR is also dependent about the myocardial segment supplied by artery, not just by the degree of stenosis. You have to be watchful of that. Once you open the CTO, the other vessel, the donor vessel, may not be physiologically significant on your FFR, IFR measurements. And sometimes there's discrimination between the rest and hyperkinesis, then you have to use the clinical judgment. Don't use this for ACS, heart failure, because you're assuming the pressures are zero and SVGs, not much data to support it. So what is the evidence? I'll quickly rush through that. deferred trial, you have now data up to more than 15 years out that you could safely defer lesions which are non-significant on FFR. FAME trial showed that the FFR-guided PCI is associated with lower incidence of MACE. The combined endpoint was lower, but the individual endpoints was, there was a trend towards that, but not lower, statistically significant by themselves, but MACE was lower. Now, FFR FAME 2 trial, this was a trial which came after Kurdish trial. This in the stable coronary disease not showing any benefit of revascularization routinely. So this FFR guided, and only about 15% or so patient had severe ischemia on the Kurdish trial. So this that ischemia, if you have clear ischemia, clear physiologic significant lesions, if you fix them in stable coronary disease, you'll see the advantage. So this green is the registry people who had FFR greater than 0.8, which was treated medically. And people who have hemodynamically significant lesions, this is the red, which were left alone. And this blue is people who had hemodynamic significant lesions in stable coronary disease who were treated. So people who were treated with stentings were similar to people in registry and had much better outcomes than people who were left alone. This was driven, although, by urgent revascularization, but a lot of these urgent revascularization had positive troponins, EKG changes as well. So FAME2 showing benefit of over a medical therapy of stable coronary artery disease. IFR Sweetheart and then Defined FAIR. Both the trials, nicely done trials, showed that IFR and FFR are equally good in terms of hard outcomes, and then the IFR is non-inferior to FFR in terms of death, MI, and unplanned revascularization. A word about your lesions, side branch lesions. So this is an example of a percentage of side branch lesions requiring further intervention in each step of provisional side branch intervention strategy. You stented, and then angiographically, the lesion appeared greater than 75% stenosis. But when you did physiology, only 31% was significant. Another trial showed that lesions which appeared greater than 70%, only 21% of those lesions, 27%, I'm sorry, of those lesions were hemodynamically significant FFR. So a lot of those lesions, if they're not flow limiting, greater than 70%, you can leave them alone because only 27% of those lesions are going to be hemodynamically significant. Flavor trial, this is an unusual trial.
कमर साहब आ रहे हैं अली भाई
ये
आपने सर पूछ रहा आपका
ये पीछे से म्यूट कर देंगे काइंडली
ये इस्लामाबाद की टीम
कैन यू म्यूट जी
नहीं बस वही आपके पास लेके हैं
ये पीछे से प्लीज म्यूट कर दें इंटरफेयर कर रहे हैं
तो डिग्गी में पड़े हुए हैं 6 वाले भी पड़ेंगे 2 गाड़ी पड़े हैं बात है जवाब सब
please mute everyone else for the time being until the talk is going on.
क्या कह रहे हैं
जन्नत वाले भी वो आना है ना सर इसमें उनका सेशन है
ना
वकास साहब
तुम्हारी आवाज
सोहेल भाई म्यूट कर देते अपना हाँ सो इसमें फ्लेवर ट्रायल में था कि they use IVIS guided FFR guided PCI and they're equally good. They use FFR less than 0.8 and post PCI FFR of greater than 0.88. And for the IVIS, they use MLA less than 3.3 millimeter square. And if it was 3 to 4 millimeters square, plaque burden greater than 70%. The MLA needed to be at least 5.5. So they were equally good. FFR guided PCI was non-inferior to IVIS guided PCI over here. FAME3 was a negative trial. We have shown before that multi-vessel DAD cappage is better than stenting. But, in the low syntax score trials, there's a trend towards being FFR guided revascularization. There's a trend towards that being better. But for other lesions, cabbage was superior, as has been shown in previous trials as well. So we didn't have a winner over. We're all looking forward to physiologic multi-vessel disease revascularization, but it didn't show advantage over cabbage. What about acute coronary syndromes? The Dynami, Primalty, FFR acute, no advantage of FFR guided PCI and non-control lesions over there. And also these negative trials, Future and Flower MI, did not show advantage over there either. So you should not be using in ACS patients. Adding FFR in multi-vessel disease, net downgrade is that, this is an example of high syntax score over here, in red. And it was 32% patients high syntax score, that became 20% when you did FFR syntax score. And 34% with medium syntax score became 21%. So this number of low syntax score grew significantly with FFR. Now, FFR guidance better with angio-guided guidance. This is a large 23,000 patient registry data, and you can show clear advantage of FFR over angio-guided PCI in hard endpoints of mortality as well, and ISR and stent thrombosis. And also, this is comparison hard points in FFR guided PCI with angiographic guided PCI. In large trials greater than 500 patients, when performed in right patients and right lesions, FFR-guided PCI works also on hard endpoints over here. So we have strong data to support its use. Now, I'm going to try to finish it up with the last few slides. The importance of microcirculation. Coronary angiogram detects only 5% of the total coronary tree. So you should be testing for microvascular disease as well. When would you do that? Patients with ANOCA, angina with non-obstructive coronary disease, MINOCA, myocardial infarction with non-obstructive coronary disease. So sometimes your patient use stent and still continue to have symptoms, and maybe consider arrhythmia of unknown etiology as well. So background angiography is limited. Up to 50% patient cath lab with no obstruction will have coronary microvascular dysfunction. 20 to 40% of patients treated successfully PCI will continue to have angina and may have CMD. And IMR can be measured quickly, accurately, and reliably. And abnormal IMR is now known to be associated with adverse outcomes as well. So microcirculation, conductance function exhibiting minimal resistance to coronary flow. Microcirculation is responsible for regulating and distributing blood flow, matching the needs of the local tissue. IFR, FFR measure the epicardial coronary arteries. IMR measure the microcirculation, and CFR reflection of both. So when you give hyperemia, CFR almost doubles to 2.5 from 1. Now you have wires, which apart from measuring distal pressure, can also measure the temperature. There's a proximal thermistor and distal thermistor. So if you inject normal saline at room temperature, it can measure the flow through the transit time. And using that, you can measure CFR by hyperemic flow over resting flow. And you can measure IMR, PD multiplied by temperature change there. And so this is the case example, and with which on invasive coronary angiography, there's no obstructive CAD over here. And you have normal coronary physiology with normal FFR, CFR, and IMR. And you gave acetylcholine. Now, what does acetylcholine do? With injecting acetylcholine, it causes the contraction of the smooth muscle cells by parasympathetic its stimulation. But it also has an effect on endothelial cells. It releases endothelial-derived lactic factor nitrates. So net effect is that it will not cause any vasoconstriction in a healthy vessel. But if you have endothelial dysfunction or a patient with vasospasm, the acetylcholine will make the cause spasm. So with normal indices, if you have spasm of the apical artery, then that patient in non-obstructive coronary artery disease has vasospastic angina, and you'll treat them with calcium channel blockers, nitrates, and smoking cessation and whatnot. And this is another patient, no obstructive CAD. You did measurement. FFR was non-significant with the non-obstructive CAD. CFR was significant because of this abnormal IMR, because this patient has microvascular disease. So this patient could treat with beta blockers and all the aggressive risk factor modification over here. And this patient had no response to vasoactivity, normal invasive physiology. So this has non-cardiac chest pain. You can tell them that it does not have ANOCA. In microvascular angina, if you have response to acetylcholine as well, that your ECG changes, chest pain, then you may have microvascular spasm as well. And you have mixed microvascular angina and microvascular spasm. And sometimes with microvascular angina, significant IMR, you have spasm of the epicardial artery when you give acetylcholine, then you have both vasospastic and microvascular angina in that case. Why is it important to do this? Now you have data supporting it as well with this project that is going on that was marked and sustained angina improvement and better quality of life at 1 year in patients who had this invasive assessment done, because you have a clear diagnosis and you can treat them. So these a lot of these patients with chest pain with non-obstructive coronary disease, the data to support their treatment as well. We're finishing up a QFR meta-analysis of proximity studies with paired analysis of QFR and FFR. So correlated very nicely. ROC curves aligned very nicely together. That's why QFR came and technology started getting used. So FAVOR 3 China trials showed that the QFR was much better than angiography-guided PCI. So all the excitement, now they decided to compare QFR with FFR in a randomized trial for clinical hard outcomes. But unfortunately, last year, this trial was presented at the TCT. The CathWorks, the whole company had big sponsorship at the TCT, but this trial came back negative. QFR-guided strategy 6.7% versus FFR-guided strategy 4.2%. So for now, I'm not ready to rely on QFR for lesion assessment, and we still have to rely on invasive assessment. What do the guidelines say? They get a class 1 recommendation for intermediate stenosis, and the same with the CCH guidelines. They've given a class 1 recommendation as well. And I'll end with this. The value of experience is not in seeing much, but in seeing wisely. And I think we'll have 15 minutes of discussion now. The floor is yours. In terms, the panelists can please chime in now.
My only contention is that, everyone should be trained, I agree. But we have to, your very important part was that the availability of equipment and expertise. So we have to have a certain critical level of deployment, यानी at least 50 to 60% cath labs जब पाकिस्तान में हो जहां ये इक्विपमेंट हो तो फिर हम इसके ऊपर असेस कर सकते हैं और इसको प्रमोट कर सकते हैं. द प्रॉब्लम इज दिस that if still you do not do IVUS guided PCI without an angiogram. You have to have an angiogram. Angiogram is the basic जिसके ऊपर आप फिर ये सारी further technology place करते हैं. It is a similar analogy is like calcium. Now I have IVUS, but I hardly ever used IVUS except when I get in trouble. Now, calcified lesions को आपने देखा है कि if you have IVUS and you see the calcium and you are trained in a US like environment, what will happen is कि 270 से ज़्यादा होगा, आप उसको upfront वो करेंगे atherectomy या IBL या जो भी. So imagine the expense of the procedure. 95% in my view, whatever the calcium is on an angiogram, अगर आप persist करें with NC balloon, OPN balloon, you probably will be able to get enough lumen, and we do that cases here. So the question is that you stop trying harder. So my only contention is, in conclusion, that आप जरूर ये टेक्नोलॉजी में सब लोग नए नए फेलोज ट्रेन हो, लेकिन जब तक कि हमारे पास अवेलेबिलिटी ना हो मेजॉरिटी ऑफ कैथ लैब्स में, दिस इज नॉट गोइंग टू बी प्रैक्टिकल. सो यू नीड टू हैव द नॉलेज, but doesn't mean that you go away from taking 5, 6 orthogonal views, different views in an angiogram, rather than just relying on a couple of angiographic views and then doing IVUS and then carrying on. So I think that there has to be a balance because of availability of equipment. Technology तो आगे बढ़ती जाएगी, but उसकी expense को भी हमें साथ रखना है.
This and I'm not sure बाकी कितने थे जो इसमें आ गए. दूसरा ये कि देखिए there's different aspects to it. एक तो जो सेहत कार्ड वाला सेहत कार्ड का सिस्टम चला है ना, one balloon, one wire, one catheter, और जो प्राइमरी PCI भी दाएं बाएं हो रही है, हर जगह हो रही है, उसके कॉस्ट इज सच एन इम्पॉर्टेंट थिंग कि उसके फायदे तो मरीजों को काफी हो रहे हैं. But in the process, we are de-learning some of very important issues about decision making in angioplasty. मतलब वायर डाली, balloon किया, aspirate किया, छोड़ दो. तो primary PCI is a different breed of animal, and then compared to a planned complex angioplasty. And so अगर अपने हमारे लिए we naturally all understand कि हम इतना ज़्यादा इस्तेमाल कर सकते, लेकिन we must do some, and उसके अंदर we can at least learn. For example, up in US and other places where there's a medical legal aspect and the cost is not, they will have to do it now, and it improves the outcome. There's no doubt on this. The value is undisputable. It is useful. It has improves outcome, and खासकर लेफ्ट मेन के अंदर, बहुत बड़ी वेसल्स के अंदर, बाइफरकेशंस के अंदर ये इसकी बहुत बड़ा इंपॉर्टेंस है. जैसे आप FR का आपने जिक्र किया कि बिफोर डिसीजन अबाउट दी कि साइड ब्रांच की FR कैसी थी. आई थिंक बाइफरकेशन में इट्स नॉट जस्ट कि प्री स्टेनोसिस कितनी थी, इट्स आल्सो पोस्ट स्टेनोसिस कितनी थी. सो ये करायना शिफ्ट के बाद क्या होना है. So sometime आपको उसको भी ज़हन में रख के अपनी bifurcation strategy plan करनी है. You might end up with a two-cent strategy just because you think this side branch is going to get down on you. So what we do is with the limited IVUS and these options we have, okay, we learn, we do a PCI and do an IVUS, and then in ordinary cases जब हम balloon की sizing कर रहे होते हैं, तो we ask each other कि what's going to happen अगर हम IVUS कर रहे होते हैं. IVUS क्या था? नहीं सर, ये तो हम 375 balloon लेते. So so you can learn from this. So जितने भी limited आप cases करें उनमें से you must learn this experience के कि IVUS क्या बताएगा आपको ना, and call it virtual IVUS or whatever. But that also helps with your own experience. You see it with your own hands. लेकिन everybody has to go and do IVUS. और आप जब भी IVUS center से आएंगे तो आपका quarter to half size बड़ा होगा post deal का. So I think the lecture was exceptional. I really loved it. I'd want you to have it delivered for us sometime if any you have time. And thank you very much. I'd love to listen to the rest of the especially Bilal Murad bhai. It's been such a long time I saw you. You're such a आप तो ईद के चांद हैं, and मेरी तरफ से बहुत आपको सलाम, and I look forward to seeing you very soon. You're a special friend, and we miss your presence in our meetings and in our cases. And you're awfully quiet in masters. You're very noticeable by your absence, which is totally not on. It's like Waqar Yunus और वसीम अकरम आप टीम से नहीं खेल रहे तो उनकी bowling मिस हो रही है. With your fantastic cases. So please find time for us also. Thank you very much.
Thank you for a very useful comments, Bilal bhai. Yeah.
I think I'm going to echo everybody's comments that it really was an exceptional talk. You pretty much covered almost every aspect that there was to cover. Because I have my deep interest in coronary physiology, I will take exception that it needed a little bit more time, but inshallah, sometime in the future. I think the disadvantage that I have in speaking in this matter is that I lack the perspective that all of you have practicing in Pakistan, which is the resource limitations. So I'm going to try and, at least for the purpose of academics, divorce myself from that issue and just talk to you about how our practice is in the US and recognizing and respecting the limitations you have.
That's exactly what we want to hear. Yeah.
Yeah. So despite the fact that there is so much evidence, the utilization of both IRIS and FFR in the United States is actually significantly limited. In Japan, for instance, almost 100% of PCIs are done with IRIS guidance. In the United States, over the last 10 to 15 years, despite this aggressive marketing by all the companies and all the data, the numbers have really barely increased from about 3.5% back in the early to mid 2000s to just about 9% even now. I mean, numbers will shift. Somebody will say 10 or 12, but it's certainly not more than 10 to 15%, which is really a striking statistic considering the fact that we have so much data. Now, if you look at for instance, the Illuminium trial for OCT, it actually demonstrated that pre-PCI OCT changes the plan of the operator in 60% of the cases.
Yeah, it's quite impressive.
And after PCI, in 30% of the cases, they will go back and treat with more balloon dilatation. I think one of the things that I have learned over the years is that the more imaging and physiology I do, I have learned to trust my eyes less. Because like your last William Osler's quote was, that we have limitations in what we can understand with our eyes, and the hemodynamics we're poor at assessing hemodynamics for all the reasons you already mentioned. So personally, in my practice, I again living in a privileged situation where cost is an issue. It's not that it's not an issue because reimbursements are not that great, and hospitals don't. Every time you use some product, you do take away from the hospital's profit margin. So it is a little bit of an issue, but nobody stops us from using it. I mean, I would say probably 75–80% of my PCIs are driven by imaging studies, and I can tell you the amount of information that I gain from this is just invaluable. Now, the other thing is that I have personally been using imaging also to help to not just to decide whether I'm going to use atherectomy or not use atherectomy. It also helps me to decide what kind of atherectomy device I'm going to use. Because now, in the past, we only had a rotablator. But now between rotational atherectomy, orbital atherectomy, OPN balloon, and shockwave IVL therapy, imaging is tremendously helpful to define, because whether it's eccentric or whether it's concentric, whether it is superficial or whether it's deep, how much arc is involved, what is the length of the treatment involved, all of those things along and keeping into context, whether it's multi-vessel disease or single vessel disease, what's the EF of the patient, what's the LV filling pressure, all of those things do help to help decide what is the safest way of treating this complex lesion. So at least I think that in Pakistan, even if you started off with a better understanding of just keeping it for the most complex interventions, I agree it's not feasible to use it in the majority of the patient for cost reasons. But at least if you do left main or multi-vessel interventions or CTOs, at least start off with that subset and collect the data, prove to yourself that this is something that you can all do in an invaluable way and accurate way. I think it'll add a lot of value to your interventions, So
Yeah, no, thank you for useful comments. That's why Sohail, if Sohail Bhai is there, he's going to be the incoming president. I think if we can, on a society level, try to push for and ask for more catheters and more, we can bring the price down, hopefully, because it is now around 2 lakh rupees for the IVUS catheter and same with the IFR wire. So the cost is limiting. But if you're going to do a left main PCI and if it's going to be complex bifurcation stenting, the patient is spending around 6 lakh rupees. If you tell him that this is going to have better outcomes if I use imaging and you spend extra 2 lakhs, I don't think anybody would mind spending 8 lakh versus 6 lakh if you tell him that it has impact on hard outcomes. And if I tell my patients they're willing to spend that, and there are a lot of patients who can't afford it in the government setup, then, we can at least try to offer them to complex lesion. Because if you don't use this, then you lose your skill set for that as well. And then when you have to use it, then you'll be thinking about, we're going to take it out, we're not going to be able to decide it. So it's important when you're not using it, have your staff train with the setup on a weekly basis. So then when you want to use it, it's just the equipment is pulled in within 5 minutes, it's ready to go and ready to use. I think it's essential to learn the skills for imaging and physiology and be able to use in your lab. All interventional cardiologists should know how to do it. Because of cost constraints, we do have limitations over here, but I think all the fellows who are coming out should get training in it. And and I'm just puzzled by why in US the numbers haven't gone up as much as you would have wanted. But I'm seeing more and more use. I think as the new data comes out and new numbers come out, probably we'll see a big jump in the numbers in the upcoming data, probably. I mean, at our data, and I don't know, in your institution, I know you're talking about nationwide, but how much do you use in your institution imaging for your cases?
So it varies. We are about 6 interventionists, and it varies from operator to operator. Some of them are using it at probably less than 20%. I'm probably more on the 70-80% side. So I would say that at least half of them, in general, are. One of the things I always tell, my colleagues as well and staff as well, is that there is this misconception that one of the greatest deceptions in interventional cardiology is looking at the compliance chart of a balloon or a stent. We assume that when you take a 3.5 balloon or a stent and dilate at 18 atmospheres or 20 atmospheres, that you achieve 3.72. That's completely false. Because those, and I have checked with the engineers of Boston and Medtronic, and they have confirmed this thing. As you know, those compliance charts are created in water, and inside a blood vessel. When you, because when I do IVL or rotational atherectomy or OCT, whatever, OPN, I'm usually doing it pre and post that intervention as well as post stenting to see the luminal gain, and I can tell you that consistently the luminal area and the diameter is always smaller than what you think it is. And that, I think, is where the value of imaging and physiology is, where you don't walk out saying, I've taken a 3.5 and see it's now 3.7 millimeters in diameter. That is simply not true. It may or may not necessarily make a difference to a lot of patients, but it will make a difference to many patients. So that's why I think imaging is important.
Bilal bhai, sorry to interrupt. We do an IVUS in a calcific vessel, and we find that we wanted a 3.5 end result, and we do an IVUS. We gave a 20-25 second inflation, and the MLA is like 3 something, a 3 millimeter dia, and it's underdeployed. But if you start to optimize these, there's big tendency of rupture for these calcific vessels also. So what would you be doing with these? I mean, I tend to go back to the same balloon and give a longer inflation, hoping that it'll, rather than oversizing the balloon. And that's a bit tricky. You try and follow with a higher size, and you might end up with a rupture.
That's a very important point, Sohail bhai, that you raised. We have to be mindful that 5.5 millimeter square area may not be applicable to a lot of our patient populations. You have to look at the distal reference lumen area as well. And as long as you're getting more than 90% of that, that is also okay. And it's a well-opposed stent, and you're getting at least 90% difference, and you don't have to stick to 5 millimeter square area. And plus, especially if it's further down in the mid or distal LED, or further down in the circ. But for the proximal vessels, you would want, and you will generally get at least 5.5 millimeter square area. But you have to then use the distal reference as well.
So the old question of a well-expanded stent. So the old question of well-expanded stent and a fully well-approximated struts and a fully expanded stent. I mean, that question always comes up every now and then.
So the opposition,
important to recognize that these numbers are basically driven by data in the Caucasian population, the white population. White men who are 5'10" and 60 feet tall don't have LEDs that are less than 3.5, 3.75, left main less than 4.5. That data is not true in our Pakistani population or in the Southeastern population. So I think we need to be very careful about trying to get fixated with these numbers and instead look at the individual patient, look at their vessel size and address the percentages based on that individualized patient, not try to get fixed to a 5.5 or 5.5 millimeter squared, because we don't have the data in our population.
Yeah, that's exactly right. And, that's why, using the distal reference segment as stent sizing and generally undersize, and then you can always expand it and be careful not to achieve the 5.5 in our population. That's a very good point, Suhail bhai, that but the numbers has to be, as far as opposition is concerned, if it's grossly malopposed, it matters, but a little bit of malopposition didn't seem to pan out to be as bad as we thought. But a well-expanded stent is more important to the proximal and reference distal reference diameter.
If I may come back, if you have a second, I can come back and address Suhail bhai's first question to me. So like I think we will all agree that the first intervention that a patient has is going to be the most important intervention the patient will ever have, because all future interventions will be guided by the result of the first one. Out here, for instance, I have seen so many patients who have had 2 layers or sometimes 3 layers, and there has been no imaging. And when you look at the first stent, there was no lesion preparation or there was no adequate sizing. And in the subsequent makes it even worse to treat. And then these patients become frequent travelers, and they come every 4 to 6 months. So to answer your question, I think the critical thing where I find IVUS is in lesion preparation. How do you achieve the maximal luminal diameter in the luminal area at the very, very first one? And that's where I said earlier that it helps me. So I don't believe in very high pressure inflations, by the way. There's been data that has been shown that trying to inflate balloons more than 16 to 18 atmospheres is not actually helpful. It causes a lot more trauma inside the wall. And that may actually cause more inflammatory reaction. What is more important is, I think, to prep the lesion, crack that calcium, and get the expansion properly. And then you can have normal. My concern with IVL therapy, I've had a few perforations, for instance, is that the IVL causes such deep fractures in the vessel wall that when you try and do high pressure inflation, you can actually cause a perf after IVL in the post-dilatation phase. So helping to decide about the sizing of the OPN balloon, which is always half of a size less than a native vessel size for de novo lesion, and also slightly undersizing for the IVL is very important, and that cannot be done without intravascular imaging. And hence, I think the need to ensure that as Pakistan tries to do this, that we really limit it to the highest risk category patients and not to the the more routine PCIs.
All right. On that note, I think it's been a very interesting discussion. Abdul Hakim, is he on board? Or Tahir Saghir Saab, are you on board as well? If you want to make some comments before we end.
Naman bhai, I beg leave for the other session.
Thank you very much for joining.
It is such a pleasure, Naman bhai, Bilal bhai. It is such a pleasure to listen to all this. Thank you very much.
Inshallah, see you in April. I'll
looking forward, Bilal bhai. I'll hold you to it.
Naman, can I make a comment?
Yes, please, Shabazz bhai. Yes.
And I have a slightly different angle. I'm not a practicing interventionalist, but imaging person and general cardiologist. So what I have seen in carotid arteries is, like, you see the imaging angiogram, 70% lean, but the eyes and ears are the ultrasound, and you see it, the lean, and then the Doppler, I call it the FFR of the carotids. With the Doppler, you decide how much severity of the lean is there. And I have seen like 70%, 60% ugly looking lesions, but the FFR of the carotid is not significant. You leave them and they behave for years altogether very nicely. So one of the questions would be, like, which technology would you rely on, IVUS or FFR? One question. The other thing which I really want to comment is that it is a 1A indication. We should be using more and more Of course, we talk about the cost and everything, but I think this should be part of the curriculum for the interventional cardiology FCPS, that everybody who is passing that must have seen and done some cases so that when they go out in the market, they are very well prepared. So no question about that. But my question, I go back to my first comment that imaging alone is not sufficient. You have to go with the physiology, with the FFR. I think that is very, very important.
So
And
that's
one other point is that when we are sending patients for cabbage, should we be doing FFRs so that we can tell the surgeon which vessels they should be doing?
So very valid points. The FFR guided syntax score does come down and reduce the high syntax score to moderate or lower syntax score. So we have seen that. And, does it have an impact if you do an FFR guided, cabbage? We don't have data on that, but I guess that's a good point. That was not physiologically significant in the graft over there, probably, especially for a Lima. To LAD, you want to be sure that it's a physiologically significant lesion, then won't work. The point regarding before revascularization, whether we should FFR, or IVUS, I think IVUS should be used more for stent optimization, getting the right optimization of the lesion and stenting optimization over there, rather than for intervention decision. I think IFR, FFR is more valid. You can defer based on IVUS if you have, let's say, a 6 millimeter square area in the left main, or more than 4 millimeter square area in any non-left main vessel, then I think you can safely defer that vessel and say it's not hemodynamically significant. But anything beyond that, it's hard to be sure, unless it's a clear clinical scenario and it's a greater than 90% stenosis. It's hard to be sure whether that lesion is going to be, if it's intermediate stenosis, then you need to do an IFR, FFR to confirm the lesion hemodynamic significance before you intervene on it.
And we should be doing CFR mostly in normal-looking coronaries before labeling the patients that they have Minoka or not.
So regarding Enoka and Minoka, that's a very good point. The CFR will be abnormal if there is an epicardial lesion, or IMR is abnormal as well. CFR measures both. But more than that, the IMR you can measure. And if you measure the IMR and it's abnormal, then you have a diagnosis for microvascular disease. And a lot of these people continue to have chest pain and are ignored. You don't have cardiac chest pain, but they're having microvascular angina. So doing that IMR can help and give them a clear diagnosis. And if you've seen that you can treat better and you have better quality of life as well. And instead of labeling them, you have nothing, you're crazy, you just keep having chest pain, but they have real diagnosis. And that acetylcholine can tell us about the vasospasm as well. Unfortunately, yes, we don't have that facility on the current wires that we have in Pakistan option available to do our IMR and CFR measurements. But I think the future wires that come over here as well, they'll add thermistors to it where you can measure temperatures as well. With that, we can measure flow, and that can give us CFR and IMR measurements as well.
Naman, if you're not aware or not, but the Abbott Vascular actually has the wire already. So we have a robust program here. I don't know if it's available in Pakistan or not, the CoreFlow wire.
I have the Boulder console with the Virata wire. That does not have that option, but they just came out with the new wires in Lahore now. I actually texted them to ask them if that feature available. He didn't know about it as of now.
So the Abbott Vascular has a CoreFlow
Boston
wire.
doesn't have that option, but I'll check with them. The new wires probably they must have it then. Yeah.
It's Abbott.
It's
Sorry.
Abbott. Okay. No, so we don't have Abbott here. We have Philips and we have Boston. We don't have Abbott here. So, but that'll be great on the same wire as the Abbott has, that you can do, for patients with the NOCA, you can do these measurements. And for these patients who continue to have chest pain with non-obstructive coronary artery disease, it's good to give them a clear diagnosis when you're there, whether you have vasospastic angina, whether you have a microvascular disease, or you have a mix of both sometimes, as we have seen. I think we'll end the session now. Thank you, Bilal Bhai. Somebody had a question. Somebody was trying to say something there. I just about to leave. It's very interesting, and I think all the points are very valid. Numan, your excellent lecture. But I just want to again re-emphasize this point. The reason that 9 to 10% in cath labs are doing IVUS and image guiding in USA, there must be a reason.
The reason is that, market forces do take to this. Technology will keep on improving, the impellers and all that. Can we afford a 25 lakh impeller? How much? Initially, there was a lot of ahoo, but the studies have not, the clinical significance is not there yet. I mean, we are doing rotas for years and years and years, and now we have IVL and all the other things as well. The device companies will keep on increasing. We as physicians have to keep a balance. If the patient's outcomes are fine and the patients are doing well, the physicians will not change. This is the reason why in US people are not doing that much, because unless they believe that their patient, if the patient outcomes are not good, the patients will not come back. They will ask for this, and the market forces will dictate. So I'm not surprised that 10 to 11% of US physicians are doing, despite the availability and the regulation. So this is a bit of a controversial comment, but I think in Pakistan we have to be a little bit careful about cost. Cost is very important.
I think that is very important, but I was hoping to hear from you as one of the key players in interventional cardiology in Pakistan, that you will push for it more, because
yes, of course.
we are
What
really
I'm
less
saying
than
is
1%
everyone
use.
should be trained. No,
Yes.
everyone should be trained. The
and yes,
tertiary
that's
centers
why we
should
have
have
it
everything.
we have it in the curriculum, and we should all have the ability to do it and know how to do it. And but the usage should go up more than, it's like less than 1%. And I was called to do an IVUS at a center where they had the machine, but since it hadn't been used, actually the चूहों ने कतर लिया था तार को ठीक है बड़े आईएस मशीन पे, तो उस तरह नहीं होना चाहिए।
लेकिन नुमान let me be a bit more. देखिए, आप सेहत कार्ड पे तो आप लोग एग्री नहीं कर. I mean, I'm one of the most expensive operators. I don't compromise on my fee. I'm not ashamed of it. आप लोग वहां पंजाब में सेहत का, आई डोंट डू, कि सेहत का सिंध में नहीं है. आप एक तरफ कह रहे हैं कि आईवस का 2 लाख का कैथेटर ले लो, दूसरी तरफ आप 2.5 लाख में एंजियोप्लास्टियां कर रहे हैं एक सेहत कार्ड पे. I mean, you have to take a stand. You say कि no, we are not going to do this. We have got to have 10 lakh rupees for an angioplasty, जिसमें हम image guiding भी करेंगे, हम सब करेंगे. फिर I agree with you 100%. Let's do it. Don't do angioplasty in 2 lakh.
To bring the cost down. वो जो आप calcification की बात कर रहे थे ना, you can actually defer doing a lot of rotas. I've seen a lot of people committed to rota over here. They came to me, I did the IVUS, and it wasn't a 270-degree arc. It got easily expanded with non-compliant balloon, but that patient had been committed to rota beforehand. So you can always defer a lot of patients as well once you have better imaging. So it's not that with imaging you always commit to rota in a lot of these patients.
You can keep on trying, or you can keep on trying harder with the balloons and the cutting wires.
Yes, a lot of times you will get through, but majority of the times you will get
through.
That's why the rota uses less. On that note, we'll end, and thank you, Nadeem Bhai, and thank you, Bilal Bhai, and Joel Bhai, for your useful comments, and Shahbaz Sahab as well. And everybody have a nice weekend. We had a nice attendance, I think 130 plus people online, and a lot of physical participation from all centers from all over Pakistan. Thank you again for joining. Have a nice weekend, everyone, and take care.
Thank you. Thank you.